Thank you for that kind introduction, and thanks for the invitation to speak to you today. So there's a lot of a big gap in terms of understanding how to treat elderly patients with HCM. So this is a typical pathologic specimen from a patient with HCM who died suddenly from sudden cardiac death. They have reverse septal curvature, asymmetric septal hypertrophy. They also have marked hypertrophy of their lateral wall, which is quite typical. So it used to be said that 1 in 500 individuals have HCM, but it turns out the incidence is probably more like 1 in 2 to 300 as we use more advanced imaging and more genetic testing. Now, in younger patients, it's typically a familial disease, autosomal dominant. It's the most common genetic disease. But in older patients, it's generally not a single sarcomere mutation. It's a polygenic disease with superimposed environmental factors, hypertension, and obesity that lead to asymmetric hypertrophy. So it's really a different disease in elderly patients than it is in younger patients. Characterized by unexplained hypertrophy, myocardial fibrosis. This is a figure from Hugh Watkins' review now over a decade ago. 4-chamber long axis in a normal, 4-chamber long axis CMR in a patient with reverse septal curvature hypertrophy. If you biopsy this patient, they'd have normal striated cardiac muscle, but in the patient with HCM, you see myofibrillar disarray and interstitial fibrosis. So CMR is the gold standard for measuring LV mass, volumes, and assessing morphology in HCM. This is a 4-chamber long axis image set in a patient with reverse septal curvature and apical, kind of mixed morphology. We can measure LV outflow tract gradient and mitral regurgitation, but that's really the area where echo shines. But the measuring scar in the heart is important with CMR. So what's clear is that age is an important predictor of outcome in HCM. So actually elderly patients have a better prognosis, and that's probably because they have the polygenic form of the disease rather than the sarcomeric mutation. So you can see this is data from the SHARE registry. Carolyn Ho is a senior author, or the first author in Circulation a few years ago, that if you diagnose it, it's probably the genetic disease under 40, the overall composite endpoint is much higher than if one's diagnosed between 40 and 60. And if one's diagnosed over 60, you can see the prognosis is best. And that's true of every individual marker, ventricular arrhythmias, heart failure composite, or AFib composite. The younger you're diagnosed, the worse the prognosis. So in terms of medical therapies, elderly patients are candidates for all of them as well as younger patients. So generally the drugs of first choice are beta blockers because they increase ventricular diastolic filling and relaxation, decrease oxygen consumption, but don't change the incidence of sudden cardiac death. Calcium channel blockers are an alternative for those who don't tolerate beta blockers. Sometimes they can be used together, but generally not in the elderly because of issues with reducing the sinus rate. In the past, the drug of second choice or second line agent was disopyramide or Norpace, a class 3 antiarrhythmic, or class 1C, excuse me, that was used in combination with a beta blocker, and it was dropped as an antiarrhythmic because it had negative inotropic properties, but that's how it works in HCM, obstructive HCM, by reducing the outflow tract gradient. But now we no longer use disopyramide in the US because we have better drugs available as second-line agents, and those are the cardiac myosin inhibitors, mavacamten or Camzyos, that was approved in 2022, and aficamten, which I'll talk about more, which will likely be approved in the US in 2025. So how do myosin inhibitors work? They're the really novel agents. They target the myosin heavy chain beta and stabilize the super relaxed state of myosin, so that it reduces myosin head availability, thereby reducing actin-myosin cross-bridging and reducing contractility. And that's how they work. The first phase 3 trial of mavacamten was published in 2020 in Lancet. Was a study of about 250 patients randomized to mavacamten and placebo. You might look at the composite functional endpoint and say, well, the drug doesn't work that well. Only 37% met the composite functional endpoint, but that was because of the design flaw of the study. The composite functional endpoint required both a reduction of one class in New York Heart Association heart failure class, as well as an increase in VO2 max of more than a threshold. And the problem was patients often acquired only one of those and not both. For example, the peak VO2 improved by more than one in the patient group and not at all in placebo. And 2/3 of the patients improved their NYHA class by at least one. So if they had split the endpoints instead of making a composite, the drug would have looked better. But certainly it drops the post-exercise LVOT peak gradient by 47 in this study compared to 11 in placebo, and patients feel better. Their KCCQ score improves, and we use this drug all the time in elderly patients because they feel better and their LV outflow tract gradient drops. So this is not an age-limited drug. I use it often in patients over 70. I'm going to skip this slide for just in terms of time. So we now know that these drugs work for if you use them for long periods of time. The initial studies were only 6 months or so, but now we know that out to 84 weeks, based on this study published earlier this year, that the resting outflow tract gradient remains reduced on mavacamten, and the Valsalva gradient remains reduced as well. So the second agent in this class is the aficamten, the Sequoia study, and this was published just recently in New England Journal. Very similar to mavacamten in terms of its effects. The outflow tract gradient was a 24-week study, fell dramatically both at rest and with Valsalva. As soon as you stop the drug, the outflow tract gradient recurs, and 2/3 of patients improve their New York Heart Association class by at least one, and as well the KCCQ score improved. Now these drugs do drop ejection fraction, a mean of 5% on average, but that's an expected effect based on how the drug works. Generally in HCM, the ejection fraction is high to begin with, 70 to 75%. So a fall of 5% is not a big deal, but they have to be screened in case their ejection fraction falls below 55%, with monthly echoes for the first 3 months, and then 3 months and 6 months after that. I was the senior author on this paper in JACC earlier this year. And what this showed is that these drugs, for the first time, offer reverse remodeling of the heart in HCM. Because of the reduction in the outflow tract gradient, the LV mass falls and wall thickness falls, as shown in this slide in this treated patient, where it doesn't change at all in placebo. Now the question is this a direct effect of the drug on the myocardium, or is it just because of the load reduction from the outflow tract obstruction relief? We won't know that until these drugs are used in non-obstructive HCM. So this is the summary data from this study. You can see LV mass fell in the treated group compared to placebo. Maximum wall thickness fell by 2 millimeters, didn't change in placebo. There's left atrial remodeling as the outflow tract gradient is reduced, and it falls significantly. And ejection fraction, as I mentioned, fell in this study only 3%. Now, mavacamten and aficamten are excellent choices for patients with symptomatic outflow tract obstruction. In younger patients, often in patients who failed medical therapy and remain symptomatic with outflow tract obstruction, surgical septal myectomy is an excellent choice. It's basically in the right hands, completely relieves obstruction, and patients do well. I generally don't send elderly patients for this surgery because of their age, because of their often have comorbidities. There is, it's open heart surgery. The recovery is it can be prolonged, and so it's really not a good option in the elderly patient. An alternative in the elderly and for some younger patients as well, in terms of therapy, is alcohol septal ablation. Now, how does this work? The invasive cardiologist threads a catheter into the first and/or second septal perforator and blows up a balloon, injects alcohol down distal to the balloon. It's essentially a controlled infarct, and over the next several days, the basal septum thins, relieving the outflow tract obstruction. It's almost as good as myectomy. There is an increased incidence of requiring a pacemaker. There's some slight chance of recurrence of the gradient, more so than myectomy, which is more permanent. But because it's less invasive than myectomy, it's preferred aggressive therapy beyond medication in the elderly. So this is a therapeutic algorithm that's now 10 years old, published by Barry Marin, but most of it has remained the same except for the addition of now the myosin inhibitors to therapy. So if patients are genotype positive, phenotype negative, there is no specific therapy needed. If the patient's asymptomatic, no therapy is needed. We'll talk about sudden cardiac death risk in a moment, ICD indications. AFib and stroke prevention, they're treated AFib is the most common morbidity in HCM, and it's treated just like non-HCM patients with AFib. We've talked about the treatment for outflow tract obstruction, and for patients whose EF is less than 50%, that's considered end-stage phase of HCM, and should be considered for LVAD, heart transplant, etc. So these are the latest 2024 guidelines for ICDs in HCM. I won't spend a lot of time on this because it's really generally not as much an issue in the elderly, right? You're not going to be offering an 80-year-old an ICD to prevent sudden cardiac death in HCM. But generally, you're treating their symptoms. So ICDs are really more an issue in younger patients with HCM. There is one study, although non-randomized, in the elderly from the Cleveland Clinic. As I said, there isn't a lot of data in the older population, but this was a study of over 1,100 patients, mean age of 80, two-thirds female at the Cleveland Clinic over a 16-year period. And the primary outcome was freedom from death or appropriate ICD discharge. Half of the patients had obstructive HCM, and a third underwent septal reduction therapy. Mostly, the Cleveland Clinic has a biopsy what's the word I'm looking for? They generally use myectomy more than they use alcohol septal ablation, and so this was even in the elderly, myectomy was used in this study. And if you look at the yellow curves, this is patients obstructive who got SRT. Their outcome was actually superior to age-matched populations. So in the right hands at the Cleveland Clinic, even in the elderly, myectomy works. I will say at most institutions, alcohol septal ablation is preferred in the older patient. So in summary, elderly patients with HCM are candidates for similar therapies to younger patients in terms of medical therapies. The novel cardiac myosin inhibitors are fair game in elderly patients. In terms of those who failed medical therapy, in my opinion, alcohol septal ablation is a better choice in the elderly patient who fail medical therapy and need more aggressive therapies. And with that, I'll end, and thank you for your attention.